Most individuals who receive a coronary stent believe the hardest part is behind them. In one sense, they are correct. The blockage has been opened, circulation has been restored, and the immediate crisis has resolved. However, what almost nobody discusses is this. What unfolds during the first 12 months following that intervention will determine whether you remain healthy or find yourself back in an operating room. The second reality that rarely gets mentioned is that a stent does not represent a cure. It represents a fresh starting point. What you do with that opportunity rests entirely in your hands. Understanding what a stent actually accomplishes requires first understanding what went wrong in the first place. Your arteries function essentially as conduits. They transport blood from your heart to every organ in your body. When these conduits remain clean and unobstructed, everything operates as it should. But over years, sometimes decades, a substance known as atherosclerotic plaque accumulates along the inner lining of the arterial wall. This plaque consists of a mixture of cholesterol deposits, calcium, fatty material, and inflammatory tissue. It does not form overnight. It builds gradually, silently, much like a pipe that becomes coated with residue after years of constant use. The medical term for this accumulation is atherosclerosis, which simply describes the hardening and narrowing of arteries due to plaque formation. As the plaque grows, the opening inside the artery becomes progressively narrower. When that opening narrows by roughly 70%, the heart muscle begins struggling to receive adequate blood flow during physical exertion. That is when you experience tightness or pressure in your chest during activity. That condition is called angina, specifically stable angina. It indicates that the artery has become severely narrowed, but has not yet closed completely. Now, if that plaque ruptures, if its outer surface tears open, the body responds the way it always responds to injury. It dispatches platelets to form a clot. In a normal skin wound, that is beneficial. Inside a coronary artery, it is catastrophic. The clot forms over the ruptured plaque, and the artery becomes completely obstructed. Blood stops reaching the section of heart muscle that depends on that artery. That is a heart attack. The medical terminology is myocardial infarction. Myocardial refers to the heart muscle. Infarction means tissue death due to loss of blood supply. Here's the part that matters most: timing. If the artery reopens roughly 4 to 6 hours after chest pain begins, most heart muscle cells can be saved. But if 12 hours pass with the artery still closed, most of those cells will be dead. They do not regenerate. They are replaced by scar tissue. That scarring can eventually lead to a bulge in the heart wall called an aneurysm, a weakened and non-functional chamber that permanently reduces the heart's efficiency. This is precisely why the stent exists, and why the timing of its placement is so critical. The first coronary stent was implanted in France in 1983 by two physicians, Puel and Sigwart. That original device was rudimentary by modern standards, simply a basic metal scaffold, nothing more. But it worked well enough to unblock an artery and keep it open. Over the following 4 decades, stent technology underwent a truly remarkable transformation. Modern coronary stents are not merely metal structures. They are coated with a polymer, a thin, flexible layer of material that contains a drug called a cytostatic agent. Cytostatic means it slows cellular growth. That may sound counterintuitive. Why would you want to slow cellular growth inside a healing artery? Here is why. When the first bare metal stents were implanted, a significant percentage of patients experienced what is called in-stent restenosis. Restenosis means the artery narrows again, not because new plaque formed, but because the body's healing response sent too many cells to grow over the metal mesh, eventually blocking the opening again. This was especially common in patients with diabetes, whose cells tend to proliferate more aggressively. The drug in the polymer coating solves this problem. It releases gradually and precisely into the surrounding tissue, keeping cellular growth controlled enough that the stent remains open without interfering with the normal process of the artery healing over the device. Modern drug-eluting stents have drastically reduced restenosis rates. This is not a minor improvement. It changed the outcome for hundreds of thousands of patients every year. In interventional cardiology, there is a well-documented pattern that repeats itself. A man in his mid-50s, let us call him Michael, develops increasing chest tightness whenever he climbs stairs. Stress testing confirms significant coronary artery disease. He receives a stent in a major artery, and within days, the pressure he had been living with for years simply vanishes. Michael feels so well and so quickly that he begins wondering whether he might be able to reduce his medication dosages. That decision, made quietly and with the best intentions, is where many post-stent stories go wrong. We will return to Michael in a moment. A common fear among people who have just received a stent is that the device might shift or migrate inside the body. This concern is understandable. You have a small metal structure inside a major artery, and the heart is constantly moving. But here's what actually happens during implantation. The stent is mounted on a thin balloon catheter. The catheter is threaded through the artery to the site of the blockage, guided by real-time imaging. Once positioned correctly, the balloon is inflated to a pressure of 10 to 16 atmospheres, which is considerable pressure, and the stent expands forcefully against the arterial wall. It does not rest against the wall, it is pressed into it. Interventional cardiologists also use intravascular ultrasound, a small imaging probe inserted inside the artery, to confirm that the stent is properly sized and completely adhered to the vessel wall. The stent is precision fitted to the actual diameter of the artery. It essentially becomes a permanent structural part of the arterial wall. It does not drift, it does not float, it is mechanically fixed in place. There is an interesting distinction between coronary stents and those used in other parts of the body, such as the carotid artery in the neck or the iliac artery in the pelvis. Coronary stents, the ones placed in the arteries of the heart, are designed with a specific balance between radial strength and flexibility. They resist the constant pressure on the heart muscle without breaking or kinking. However, they are not completely rigid, and with extreme force they can deform, which is why coronary stent placement is always carefully chosen to avoid locations where the vessel is under significant mechanical stress. By contrast, stents placed in carotid or iliac arteries are self-expanding and virtually crush-proof. You can compress them and release them, and they recover their original shape. This design is intentional. Those blood vessels move with the body, flex with posture, and need a device that can withstand that without losing its form. Now, back to Michael and the most important point you need to understand about life after stent placement. When a stent is first placed, the body recognizes it as a foreign object. That recognition activates the clotting system, the same mechanism that would respond to a splinter or a cut. Platelets, the small blood cells responsible for clotting, begin accumulating around the metal mesh of the stent. If that process is not controlled, a clot can form inside the stent, blocking it. That is called stent thrombosis. And when a stent thromboses, the result is usually a myocardial infarction, often more severe than any chest pain the person experienced before. Modern medicine prevents this through a treatment called dual antiplatelet therapy. Dual means taking two medications together. Antiplatelet means the drugs prevent platelets from clustering and forming clots. The two medications most commonly used are aspirin, typically at a low dose of 75 to 100 milligrams, and a second agent, either clopidogrel or ticagrelor. Both act on different platelet pathways, and that is the point. One drug blocks one mechanism, the other blocks a different one. Together, they give the body two separate reasons not to form a clot in the stent. Think of them as two separate locks on the same door. The reason this is so important is timing. During the first weeks and months after implantation, the stent gradually becomes covered with a new layer of cells, the same type of smooth endothelial cells that naturally line a healthy artery. This process is called endothelialization. Once the stent is completely covered, which usually occurs over the course of about 12 months, it is essentially incorporated into the arterial wall, and the risk of clotting drops dramatically. But until that process is complete, the stent is vulnerable. That is why skipping even a single day of antiplatelet medication in the first months after stent placement is genuinely dangerous. One missed dose gives you no margin for error. There is clinical data and a valuable lesson learned over years of cardiology practice demonstrating that sudden discontinuation of dual antiplatelet therapy in the early period after stent placement is one of the most common triggers of stent thrombosis. The clotting system, which the drugs have been suppressing, rebounds quickly, and stent thrombosis is a medical emergency, a pattern that presents in emergency cardiology more frequently than people realize. Someone who had a stent placed 8 or 10 weeks earlier felt perfectly fine, and stopped taking one of their medications without concern because they ran out or did not believe it was that important. They arrive at the emergency department with a massive heart attack, precisely the one the stent was supposed to prevent. This is Michael's story, and it repeats itself in hospitals across the country more often than it should. After 12 months of dual therapy, and this is always a conversation between you and your cardiologist, not a decision you should make alone, many patients transition to aspirin alone as long-term treatment. Some patients may require longer dual therapy depending on their individual risk, but the first year is non-negotiable. Now, the stent addresses the consequences of atherosclerosis. It does not address the cause. And this is the part of the conversation that often gets lost in the relief of having survived a cardiac event. The plaque that blocked your artery formed because of a combination of factors: elevated LDL cholesterol, LDL being the type of cholesterol that contributes to plaque buildup; high blood sugar, which damages arterial walls and accelerates plaque formation; high blood pressure, which creates mechanical stress on those walls and makes them more vulnerable to injury; smoking, which directly damages the endothelium, that inner lining of the arteries, and promotes every stage of atherosclerosis. These factors do not disappear just because you have a stent. If not controlled, plaque will continue accumulating in the artery where the stent was placed, around the edges of it, or even in other arteries. The risk of needing another procedure is real and quantifiable. It is not inevitable, but it requires active management. Cholesterol-lowering medications, primarily statins, are almost always part of post-stent care. Managing blood sugar is equally fundamental, especially in people with diabetes or prediabetes, because elevated glucose accelerates arterial damage in a way no stent can compensate for. Blood pressure control, smoking cessation, and regular physical activity directly reduce the speed at which new plaque forms. These are not optional lifestyle extras. They are the medical continuation of what the stent started. And regarding physical activity, this is an area where fear unnecessarily holds many people back. If you received a stent for stable angina or an early cardiac event, you do not have a ventricular aneurysm, and your cardiac function has been evaluated and is reasonable, most people can and should resume regular exercise. Walking is always a good starting point. In many cases, with proper evaluation and guidance from a cardiologist, people can return to running, cycling, and other prolonged aerobic activities. Exercise is not only permitted, it is part of the treatment. It improves endothelial function, reduces blood pressure, helps regulate blood sugar, and lowers overall cardiovascular risk. What level of care is right for your specific situation needs to be analyzed carefully with your healthcare team. But do not assume that having a stent means you must lead a sedentary life. Often the opposite is true. A case that arises frequently in cardiac rehabilitation programs is that of a woman in her early 60s, let us call her Elizabeth, who received a stent after years of chest pain with physical exertion. In the months after the procedure, she was afraid to exert herself. She moved slowly, avoided stairs, and stopped walking around her neighborhood. At her 6-month follow-up, her cardiologist cleared her to begin a graduated exercise program. 3 months after starting, Elizabeth completed a 5-kilometer walk. She described her physical stamina as better than it had been in the last decade. That is not unusual. It is actually the expected outcome when post-stent care is done correctly. This is also a good time to address cholesterol, as it is frequently misunderstood. After a coronary event or stent procedure, the target for LDL cholesterol is more ambitious than in the general population. The general recommendation is to maintain LDL cholesterol below 70 milligrams per deciliter. That is a unit measuring the amount of cholesterol in the blood, and for very high-risk patients, even lower than 55. Diet alone rarely achieves this after a cardiac event. Statin medications such as atorvastatin or rosuvastatin are usually required, and the evidence supporting their use in this population is substantial. If you have concerns about side effects or medication tolerance, it is worth discussing openly with your physician. However, the decision to manage cholesterol intensively after stent placement is based on decades of outcome data. Here is something that relates directly to all of this. How old are you? Age influences virtually every aspect of recovery after stent placement, from how quickly the endothelium heals over the stent to what level of exercise is appropriate, and how intensively certain risk factors should be managed. So what does living well after stent placement actually look like in practical terms? It means taking antiplatelet medications every day without exception, especially during the first year. It means having a clear understanding of what your cholesterol target is and what you are doing to reach it. It means knowing your blood pressure numbers and keeping them within a healthy range. It means not smoking, and if you do smoke, making a sincere and supported attempt to quit. It means reintroducing physical activity into your life, starting gradually and following a timeline your healthcare team will help define. And it means understanding that every follow-up appointment is an opportunity, not a formality. A stent is not a sentence. As cardiologists who closely follow the life trajectory of these patients have said on numerous occasions, it is a second chance. 30 or 40 years ago, a blocked coronary artery often meant death or permanent disability. The options were limited: bed rest, anticoagulants, and if the patient survived, major open heart surgery called coronary artery bypass grafting, where a vein or artery from another part of the body is rerouted to bypass the blocked section. That operation required opening the chest completely and connecting the patient to a heart-lung machine, a lengthy and high-risk procedure that is now reserved only for the most complex cases. Currently, approximately 1 in every 150 cardiac patients needs bypass surgery. The rest can be treated endovascularly, through the artery, with a catheter, without opening the chest. That change in medicine occurred within the span of a single human lifetime. What you carry in your arteries is the result of more than 4 decades of relentless engineering and clinical science. Use it well. Take your medications, control your risk factors, attend your appointments, speak honestly with your doctor about what you can and cannot do, and demand clear answers because you deserve them. Everything in this presentation is health information. It is here to help you formulate smarter questions and understand the answers. It does not replace individualized advice from a physician who knows your case, your imaging, and your complete medical history. And no online presentation ever will.